This recorded lecture will be going over Chapter 38, Providing Wound Care and Treating Pressure Injuries, in the Fundamentals textbook. Wounds can occur in a variety of ways. The skin and mucous membranes are our protective barriers for the body against any type of infection. When our integument is injured, a complex healing process is initiated. Nurses will act to prevent the invasion of microorganisms into wounds and to support and enhance the body's ability to effect wound repair. Wounds can be open, occurring through the skin, or closed, without a break in the skin. Wounds can be partial thickness, which means superficial, or full thickness. Partial thickness wounds can heal more quickly because the skin cells are produced by the epithelial cells remaining in the dermal layer of the skin. When a full thickness wound occurs, the dermal layer is no longer present except at the wound margins. To heal a wound, all dead and necrotic tissue needs to be removed so that granulation tissue can gradually fill in that defect. That wound would heal by secondary intention. Wounds can be clean, which means free of microorganisms, or dirty. When a wound occurs, two primary methods of healing are the replacement of cells and regeneration. Replacement of cells occurs in the form of fibrous connective tissue that does not have the same functional characteristics as the tissue lost when the wound occurred. When these cells are not damaged beyond recovery, they restore themselves with little to no permanent evidence of injury. If the blood supply has been disrupted to the new wound bed and necrosis has occurred, the affected tissue then must heal by regeneration. New cells similar in structure and function to the dead cells are produced if the tissue is a type that can regenerate. Skin, mucous membranes, bone marrow, bone, liver, kidney, and lung tissue can all regenerate with tissue that is structurally like that which was lost. Heart, muscle, and central or spinal nerve cells are unable to regenerate. No matter what the cause of the wound, healing will occur in three distinct phases: the inflammatory phase, the proliferation phase, or the reconstruction phase, and the maturation or remodeling phase. Inflammation is a localized protective response brought on by injury or destruction of tissues. The inflammatory phase begins immediately after injury and will last approximately 3 to 4 days. This includes constriction of blood vessels, platelet aggregation, and the formation of fibrin from the action of thrombin on the fibrinogen and the epithelial cell migration. Hemostasis occurs. A scab will form to protect against any pathogens. Chemical reactions will release histamine and prostaglandin. Small blood vessels will dilate and become more permeable. This causes serous fluid to leak into the traumatized area. This collection of plasma and electrolytes leaking into the interstitial space will cause edema and swelling. The wound will become red, swollen, and tender. Reactions that are more chemical will bring phagocytic neutrophils to cleanse the wound. The phagocytic cells will then remove debris and protect against any bacterial invasion by phagocytosis. The clinical signs of the inflammatory process include edema, erythema, which is redness, heat or increased temperature at the site, pain stemming from pressure on the nerve receptors, and a possible loss of function due to those other changes. The proliferation stage begins on the 3rd or 4th day after injury and will last for 2 to 3 weeks. In this phase, the wound is filled with new connective tissue and new epithelium covers the wound. Macrophages continue to clean up debris, and collagen is forming. New capillary networks provide oxygen and nutrients to support this collagen and further synthesis of more granulation tissue. This tissue will be deep pink in appearance. Scarring is influenced by the degree of stress on the wound. The final stage of healing, maturation, will begin approximately 3 weeks after injury. Scar maturation or remodeling is the process of collagen lysis, or the breakdown of collagen, and synthesis by the macrophages to produce the strongest scar possible. Scar tissue will slowly thin and become paler in color. At the end of the process, the scar will be firm and inelastic. The length of each phase will depend on the type of injury and whether the wound heals by primary, secondary, or tertiary intention. When a wound occurs around a joint, attention is needed to maintain joint mobility and prevent a contracture. This is an abnormal shortening of muscle tissue. These can restrict our joint extension. If collagen overgrowth occurs, which is frequent in dark pigmented skin, a keloid can occur. This is a permanent, raised, and large scar. A wound with little tissue loss, such as a surgical incision, will heal by primary intention, also known as closure. The edges of this type of wound will approximate, which means that they will be able to get close together, and there's only a slight chance of infection. Excuse me. A wound with tissue loss, such as a pressure injury or a severe laceration, will typically heal by secondary intention. The edges of these types of wounds will not approximate, and the wound needs to be left open to fill with scar tissue. Tertiary intention is also known as delayed closure. This occurs when there's delayed suturing of a wound. There are many different factors that affect our wound healing. Age is, of course, one of them. Healthy children and adults will heal more quickly than those with chronic health conditions and our older adult population. Metabolism and regeneration in the chronically ill and older adult are slower. Peripheral vascular disease will impair blood flow, which can impede healing. Atherosclerosis and atrophy will reduce skin capillaries and impair blood flow to the wound. A decline in immune function will reduce the formation of antibodies and monocytes necessary for wound healing. Added protein and adequate fluid are of great importance when a patient has a chronic wound. A diet that is rich in carbohydrates, lipids, vitamin A, C, thiamine, pyroxine, and riboflavin, plus minerals zinc, iron, and copper are needed for wound healing. If the patient is unable to consume adequate oral nutrition, enteral or parenteral nutrition should be considered. Regular exercise will promote blood circulation and promote healing because blood will bring oxygen and nutrients to the wound. Smoking will reduce the functional hemoglobin of the blood and limit the oxygen carrying capacity. The person who does not smoke and who exercises regularly will typically heal more quickly. The use of steroids, immunosuppressants, and other anti-inflammatory drugs, anticoagulants such as heparin, and antineoplastic agents will interfere with various aspects of the healing process. Inflammation is generally a signal of infection, but it sometimes might not occur when steroids are present within the body. A wound infection will slow the healing process. A bacterial infection of the skin or mucous membranes will frequently cause fluid drainage from the wound or the damaged tissue. Patients who have a chronic illness, such as diabetes, cardiovascular disease, or a disorder of the immune system, might take longer to heal. Patients who are immunocompromised with poorly functioning immune systems have delayed wound healing due to fibroblast function, collagen synthesis, and phagocytosis are affected. These patients are at a high risk for healthcare-associated infections. Some bleeding from a wound is normal, but hemorrhage is always abnormal. Internal hemorrhage is evidenced by swelling or distension in the area of the wound, and perhaps sanguinous or bloody drainage from a surgical drain. If internal hemorrhage is extensive, hypovolemic shock can occur with a fall in blood pressure, a rapid and thready pulse, increased respiratory rate, restlessness, diaphoresis, and cold, clammy skin. Be sure to intervene promptly to prevent a potentially life-threatening situation. In some cases, a hematoma can occur. A hematoma can appear as a swelling that is a bluish red. If a hematoma is large, it can place pressure on large blood vessels and obstruct their blood flow to the surrounding tissue. The risk of hemorrhage is greatest during the first 48 hours after surgery. When it occurs, it needs emergency intervention. A wound can be infected with microorganisms at the time of injury, during surgery, or postoperatively. Local signs that a wound is infected will include increased pain, redness, warmth in the surrounding tissues, and a purulent exudate, or pus. A localized infection called an abscess is an accumulation of purulent exudate made up of debris from phagocytosis when microorganisms have been present. The fluid can be white, yellow, pink, or green, depending on the infecting microorganisms. The microorganism most frequently present in wound infections is Staphylococcus aureus. When wound infection is suspected, a specimen of the wound exudate needs to be obtained and tested. Cellulitis is an inflammation of the tissue surrounding the initial wound, with redness and induration, which is skin hardening. A fistula is an abnormal passage or communication that is usually formed between two internal organs, or leading from an internal organ to the surface of the body. A fistula can result from an infection, or it may be present congenitally. The best way to prevent wound infection is to maintain strict asepsis when performing wound care. Be sure to use sterile equipment, meticulous hand hygiene, sterile gloves, and sterile dressings. Refrain from talking while dressing a wound to prevent any microorganisms in the mouth or saliva from possibly landing in the wound. Dehiscence is the spontaneous opening of an incision. Dehiscence of an abdominal wound will often involve separation of the layers beneath the skin as well. Evisceration is a protrusion of an internal organ through the skin. Risk factors for dehiscence include obesity, poor nutrition, multiple traumas, excessive coughing, vomiting, strong sneezing, suture failure, and dehydration. A sign of impending dehiscence can be an increase in the flow of serosanguinous, this is serum and blood mixture, drainage into the wound dressing. When dehiscence occurs, the patient can state that something has given way. If dehiscence or evisceration occurs, quickly place the patient in a supine position and place large sterile dressings or towels soaked in normal saline over the incision and viscera. Notify the surgeon immediately and prepare the patient to return to surgery. Sutures and staples are typically used to hold the edges of a surgical wound together until that wound can heal. Sutures used to attach the tissues beneath the skin are made of an absorbable material. These are not removed, and they're reabsorbed or will dissolve in the body within a few days. Skin sutures are made of silk, cotton, linen, wire, nylon, or Dacron. Sometimes the wound is small, and steri-strips can be used. These are small, reinforced adhesive strips placed over a break in the skin that will effectively hold the wound edges together while healing takes place. Topical skin adhesive is a synthetic, non-invasive glue that decreases the trauma from removing a dressing while providing a seal that will protect the underlying tissue without any need for bandages. This will loosen and come off in 7 to 10 days. The recommended method of open wound classification is based on the wound's color rather than its cause or dimensions. There are 3 basic wound types: red, yellow, and black. The type of wound will indicate the type of dressing that it needs. Red wounds are clean and ready to heal. Protection is the best method of treatment. A yellow wound has a layer of yellow fibrous debris or exudate. These wounds can be yellow if a large number of leukocytes is present. Slow and necrotic tissue that needs to be removed from the wound bed may need to be removed from the wound bed so that healing can occur. Slowing is the natural shedding of dead tissue, and this can cause additional drainage. A yellow wound needs to be cleaned frequently and should have a dressing that will absorb the drainage and debride the surface mechanically. A yellow wound will often become infected. Black wounds need debridement of the eschar in order to heal. Eschar can be mechanically debrided by a surgeon, softened by soaks or enzyme substances, and gradually removed as it separates. At surgery, 1 or more drains may be placed to provide an exit for blood, purulent exudate, fluids, or air that accumulates and could increase the risk of infection. The drain may be active or passive. An active drain is attached to a wound suction device to remove any accumulated exudate or other material. A passive drain will have no suction device attachment It works by the increased pressure inside the wound and depends on the gravity and capillary action to pull out any fluid buildup. Plastic drainage tubes can be connected to a drainage system that is then compressed and closed, applying slight suction to the drainage tube to help evacuate any wound fluids. Draining excess fluid from a wound area will help prevent the formation of an abscess or fistula. The skin around the drain needs to be cleansed during every dressing change. Dressings are protective covering layers placed over wounds, and they serve a number of purposes. They prevent microorganisms from freely entering or escaping the wound, and they absorb drainage. In addition, dressings will help support and stabilize tissues and reduce discomfort from a wound. A wide variety of dressing materials are available. Choices will be based on the location, size, and type of wound, whether or not an infection is present or debridement is needed, and the frequency with which those dressings will be changed. The size and number of gauze pads will depend on the size of the wound and the amount of exudate. Telfa or other non-adherent dressings have a shiny, non-adherent surface on one side that should be applied to the wound. Exudate will then seep through the surface and collect in the absorbent material on the other side. This dressing will cause less wound trauma when it's removed because it does not stick to the wound. Surgi pads or abdominal pads are also known as ABD pads. These are used to cover small gauze dressings. They will hold the dressing in place and also absorb and collect any excess drainage. Whichever dressings are used, the purpose is to fully cover the wound and supply sufficient absorbent material to contain any exudate produced. The outermost dressing should completely cover the inner dressings. Wounds will heal faster when they're kept moist rather than when they're kept dry. Two commonly used dressings are transparent film and hydrocolloid dressings. It's very important to determine the desired action for treatment of the wound before you choose the dressing. Transparent film dressings, such as Opsite or Tegaderms, will allow you to assess the wound without removing the old dressing. The transparent dressing does not require the use of tape and is often less bulky than a gauze dressing. These dressings are often used to cover intravenous catheter sites and are sometimes used to protect stage 1 or 2 pressure injuries. They will not absorb any drainage, so they can be used as a secondary dressing to secure a primary wound dressing that will absorb the wound exudate. A transparent film dressing should be changed when it no longer adheres to the skin properly. Do not use a transparent film dressing over an infected wound. Hydrocolloid dressings such as Duoderm will keep a wound moist and have been able to shown to reduce wound size. They are water and air occlusive and self-adhesive. Once applied, this dressing can stay in place for 3 to 5 days, provided that it stays in contact with good skin on all edges. Hydrocolloids are not recommended for any heavily draining wounds. Necrotic tissue that needs to be removed from the wound before healing can occur. Sharp debridement is performed at the bedside or in the operating room. This can be done using sterile scissors, forceps, and a scalpel blade. Sharp debridement should be performed whenever there are signs of cellulitis or sepsis. This is a very painful procedure, and the wound will bleed afterwards. Nurses can often be directed to perform enzymatic debridement. This will use topical substances to break down and liquefy the dead tissue. These substances are placed in the wound, and another dressing is placed over it to hold it in place. This can be very useful for uninfected wounds. Chemical debridement using a Dakin solution or sterile maggots is occasionally used on a wound with necrotic tissue that is not responding to any other treatments. Autolytic debridement is a longer process that will use the body's enzymes to break down non-viable tissue in the wound. This is best to be used on small, uninfected wounds because the type of dressing used will provide a warm, moist environment that could encourage the growth of bacteria if present. Mechanical debridement is the physical removal of wound debris by irrigation or hydrotherapy with a whirlpool bath or an ultrasound mist. These treatments are usually ordered 3 times a week. The procedure is usually painless, but it can be followed by tingling and redness at the site. Wet to dry dressings are an older form of dressing changes that will mechanically debride because the tissue will stick to the dressing material and a layer of cells will be pulled off when the dressings are removed. These are no longer recommended because they disrupt newly regenerating tissue. The dressing needs to be secured to the wound using tape, stretch roller gauze such as Conform, Curl-X, or Cling, mesh netting, an elastic bandage, or Montgomery straps. The correct product needs to be selected for the purpose. Montgomery straps will allow changing of the dressing without removing and reapplying the tape. This can cause repeated skin irritation. Do not apply tape over irritated or broken skin. To remove the tape, gently loosen the tape ends and then gently pull each parallel to the skin surface towards the wound while applying light traction to the skin away from the wound as the tape is loosened. If the tape still will not loosen, you can use an adhesive remover. Binders are wide elasticized fabric bands, and these are used to decrease tension around a wound or a suture line, increase patient comfort, decrease lactation after childbirth, or hold dressings in place. An abdominal binder will provide support and comfort for an abdominal incision when the patient needs to perform deep breathing and coughing exercises, as well as getting in and out of bed. Wounds that are difficult to heal might respond to negative pressure wound therapy, or NPWT. This treatment can increase the development of granulation tissue, speed up the healing rate, and reduce hospitalizations when used to treat wounds healing by secondary intention. The therapy is also known as vacuum-assisted closure. This involves applying a suction device to the special wound dressing to institute negative pressure at the wound site, which will draw those edges together. NPWT will keep the wound moist. Dressing changes for this system will depend on the type of wound being treated. If the wound is infected, the dressing needs to be changed every 12 to 24 hours. Contraindications to the use of NPWT include beating, bleeding, exposed organs, exposed blood vessels or nerves, and malignant or cancerous tissue. Clean ulcers or pressure injuries at every dressing change. Use 250 to 500 mL of solution and irrigate using a syringe with a small catheter to reach any undermined areas or tunnels. Observe and document wound characteristics at every dressing change. For infected pressure injuries or ulcers, always use a non-occlusive dressing. Chemical enzyme formulas can be used in the wound to help debride any eschar in stage 4 pressure injuries. Sometimes a wet to dry dressing also may be applied to help the slowing of necrotic tissue by mechanical debridement. An unstageable pressure injury will need eschar debridement chemically or mechanically before any healing can begin. Assessment will include complete inspection of all skin areas. Every abrasion, laceration, contusion, reddened area, ecchymosis, and incision needs to be noted. The location and appearance of wounds should be documented daily in specific terms because changes can occur rapidly. Assess the wound by visual inspection, palpation, and smell, noting the wound's appearance and any drainage, swelling, odor, separation, and complaints of pain. Carefully assess the site for any surrounding edema. Assess whether the signs of symptoms of local or systemic inflammation or infection are present. Do this by reviewing temperature trends, white blood cell count, and any patient reports of discomfort. A temperature greater than 101, a white blood cell count greater than 10,000, and a feeling of malaise can indicate a wound infection. It's important to note that in a dark-skinned person, you need to rely on localized skin color changes at and around the wound site. The affected skin can be darker or shinier than the surrounding skin. Moderate postoperative pain is normal for 3 to 5 days, but persistent severe pain or sudden onset of new pain can indicate infection or internal hemorrhage. And if the initial dressing is in place, don't touch it until the primary care provider changes it or leaves orders for the nurse to do so. It's also important to assess the patient's reaction to the wound and their readiness to learn how to perform wound care. Be sure to document your findings after every dressing change. Include time for wound assessment and care planning in your workload. Dressing changes can always require a medical order, and wound irrigations can be performed only with an order. Be sure to determine what supplies will be necessary for a dressing change or irrigation. When implementing wound care, the nurse needs to use the principles of asepsis. Use standard precautions for all patient care, particularly during wound care, when one comes into contact with body fluids. Use sterile gloves or sterile forceps whenever you touch an open or fresh surgical wound. Clean wounds with water, normal saline, or a non-cytotoxic wound cleanser. Using cold solution will lower the wound temperature, and that can slow healing. Clean grossly contaminated or infected wounds at every dressing change. Cleaning a healthy wound incorrectly can cause mechanical trauma and delay healing. Use gauze pads rather than cotton balls for cleansing because cotton fibers can be embedded in the wound and delay healing. Avoid drying a wound after cleaning because it will heal better if it stays moist. Hydrocolloid dressings are applied only to uninfected wounds. They will keep the wound moist and block entry of microorganisms. There are a variety of hydrocolloid dressings available. Irrigation is the flushing out of an area with a liquid. Wound irrigation is performed only with a medical order, and it does require sterile technique. Either a wet to dry or wet to damp technique can be used. Moistened gauze packing is placed in the wound to absorb any exudate, but it's not allowed to dry before removal and therefore will not damage the newly formed tissue. Before the patient is discharged, teach proper technique for cleaning and dressing the wound. Send the patient home with enough dressings to last until someone can purchase the needed items. And be sure to send written instructions home with the patient to reinforce all patient education. Suture scissors, forceps, and sterile technique need to be used to remove sutures. Inspect the suture after it is pulled out to see if it is whole. Irrigations need to be performed when there is a possibility of debris or caustic substance in or near the eye. Using standard precautions, irrigate the affected eye with prescribed solution, usually sterile saline or tap water. Ear irrigations are used to remove cerumen or foreign bodies that occlude the ear canal and prevent sound from reaching the tympanic membrane. Ear irrigation is ordered by the primary care provider and should not be performed if there is any possibility that the tympanic membrane could be perforated. Sometimes an ear jet irrigation system with a specialized nozzle is used. Caution should be exercised, using only the lowest setting, as damage to the tympanic membrane is a serious complication. A vaginal irrigation can be ordered for infection or surgical preparation of the vagina. Frequently, the patient will administer that irrigation themselves. Either dry or moist forms of heat and cold can be applied to the body to promote healing. Usually an order is necessary for this treatment because systemic and local effects will occur. Assess the circulation in and around the area to be treated. When cold is applied to a lower extremity, assess for capillary refill, note skin color, and palpate skin temperature and distal pulses so a baseline of the area can be documented in the medical record. Heat is applied to skin surfaces to provide general comfort and speed the healing process. Systemic circulatory changes can cause faintness, a faster pulse, or some degree of dyspnea. Heat can be applied locally by means of a hot water bottle, an electric pad, an aquathermia pad, or a disposable heat pack. Moist heat can be used in the form of compress, hot packs, soaks, or a sitz bath. To protect a patient from burns caused by heat applications, Measure the temperature of the liquid when possible. Use a flannel or cloth to cover all hot and cold packs. Hot water bottles should be filled 2/3 full and the air needs to be expelled, then the plug attached. Infrared heat lamps will be typically used for 15 to 20 minutes per session, 3 times a day, and need to be placed 18 to 24 inches from the area of treatment. When hot compresses are ordered, heat a solution to the temperature ordered. Dip the gauze or cloth in the solution and then wring it out. Use sterile technique, including sterile gloves and supplies, when there is broken skin in an area of treatment. In the home, hot compresses can be made with washcloths dipped in hot water and wrung out. When a soak is ordered, submerge the part to be treated in warm water or solution for 15 to 20 minutes. Whenever heat is used, you need to ensure the patient's safety. On page 802, see the safety alert, safety factors when applying heat. Heat is usually not applied immediately after injury or surgery because it will increase bleeding and swelling. Cold is used for 2 main purposes: to decrease swelling and decrease pain. Systemic effects of cold are the reverse of those of heat. Cold is applied in the form of compresses, packs, ice bags, ice collars, or hypothermia blankets. Most disposable cold packs are applied directly to the skin. However, follow your manufacturer's directions. Ice bags and ice collars are reusable. A hypothermia blanket should be used to lower body heat for any patient running a persistently high fever. A cooling blanket is attached to a machine that supplies the blanket with a cooled solution of distilled water and 20% ethyl alcohol. Most cold treatments will require an order before application. Carefully assess the skin and circulation in the area of application and distal to it before, during, and after treatment. Assess the caregiver's ability and availability to administer hot or cold treatment safely. Caution the patient and family members not to heat washcloths or other linens in the microwave because a fire could occur. This method of heating items in the microwave will also produce uneven heat distribution and can increase the dangers of burning the patient. General goals for the patient with wound care and wound healing include that the wound edges are well approximated. The wound needs to be clean and dry without redness or swelling. The patient should state that their pain is gone and that their energy has returned. A return demonstration of the dressing change is needed to see that the patient can perform it properly.